Welcome to Studious. Today we begin one of the most strategically important and frequently examined subjects in the entire medical curriculum, community medicine, also known as Preventive and Social Medicine, or PSM. While clinical subjects like surgery and internal medicine focus on treating individual patients who are already sick, community medicine asks a far more powerful question. How do we prevent entire populations from becoming sick in the first place? This discipline operates at the intersection of medicine, public health, epidemiology, biostatistics, and social science, and it is the foundation upon which all national and global health systems are built. For MBBS students, community medicine is one of the highest scoring subjects in university examinations because its concepts are systematic, logical, and highly pattern-based. For USMLE Step 1 and Step 2 candidates, public health and preventive medicine questions consistently appear throughout the examination. In this lesson, we will build the complete framework of community medicine, covering levels and modes of prevention, chemoprophylaxis, the disability continuum, rehabilitation, global health organizations, and the critical high-yield terminology distinctions that appear repeatedly in examinations. Let us begin building your preventive medicine blueprint.
The entire architecture of disease prevention in community medicine is organized around one master matrix, a table that every medical student must memorize cold because it is the direct source of some of the most commonly asked MCQ questions in MBBS examinations. The matrix has 4 columns: the level of prevention, the disease state at that level, the mode of intervention, and the clinical goal. Let us read it row by row. Primordial prevention operates at the pre-risk factor stage, before risk factors have even established themselves in the population. Its mode of intervention is health promotion, and its goal is to prevent risk factors from ever developing. Primary prevention operates at the pre-disease stage. Risk factors exist, but clinical disease has not yet appeared. Its modes are health promotion combined with specific protection, and its goal is to prevent disease onset entirely. Secondary prevention operates at the early disease stage. The disease has begun but is still reversible. Its mode is early diagnosis and prompt treatment, and its goal is to halt progression and reverse damage. Tertiary prevention operates at advanced disease. Irreversible structural damage has occurred. Its mode is disability limitation and rehabilitation, and its goal is to restore function and prevent social handicap. 2 critical MCQ alerts. If asked for the best level of prevention, always choose primary. If asked for the best mode of intervention, always choose health promotion.
Primary prevention is the most important level of prevention in community medicine, and it operates through 2 complementary but distinct arms that work together to prevent disease onset in a population that has not yet developed clinical illness. The first arm is health promotion, a general, population-wide strategy that strengthens overall health and resilience without targeting any specific disease. Health promotion encompasses 3 broad domains. Education and lifestyle interventions include promoting physical activity, adequate sleep, sex education, and marriage and genetic counseling for couples at risk of passing on hereditary diseases. Environmental interventions include improving personal and community hygiene, sanitation infrastructure, safe water supply, and modifying environmental conditions that predispose to disease. Nutritional interventions include reducing consumption of processed and ultra-processed foods, increasing whole food intake, and establishing periodic medical checkup habits. The second arm is specific protection, targeted interventions aimed at preventing specific, identifiable diseases in susceptible populations. This arm includes immunization programs, both routine expanded program on immunization schedules and mass campaigns like Pulse Polio. It includes nutrient supplementation to prevent deficiency diseases, vitamin C for scurvy, vitamin D and calcium for rickets, and vitamin B1 for beriberi. And it includes occupational defense measures, engineering controls, personal protective equipment, and legislative regulations protecting workers from hazardous occupational exposures.
Within the specific protection arm of primary prevention sits one of the most examination-intensive topics in all of community medicine: chemoprophylaxis. Chemoprophylaxis is the use of drugs or chemicals to prevent the establishment or progression of infection in exposed or susceptible individuals before clinical disease develops. It is divided into two mechanistic categories. Causal prophylaxis directly eliminates the causative agent. The drug kills or removes the pathogen before it can establish disease. Clinical prophylaxis prevents the clinical manifestations and symptoms of disease. The infection may still occur at a subclinical level, but the drug prevents it from producing symptoms or complications. Now let us walk through the high-yield drug table systematically. For malaria, one of the most examined diseases in community medicine, the prophylactic agent is chloroquine, taken by individuals entering malaria endemic zones. For tuberculosis, the prophylaxis is isoniazid, given to close contacts of smear-positive TB cases, alongside BCG immunization at birth as the primary vaccine-based protection. For rheumatic heart disease, benzathine penicillin is given monthly as secondary prophylaxis to patients who have already had one episode of rheumatic fever, preventing further streptococcal attacks and progressive valvular damage. For diphtheria and pertussis contacts, erythromycin is the prophylactic agent of choice. For meningococcal meningitis contacts, rifampicin is used to eliminate nasopharyngeal carriage and prevent secondary cases.
Secondary prevention operates at the most clinically urgent juncture in the natural history of disease, the reversible window. This is the critical period after disease has begun, but before irreversible structural, functional, or biochemical damage has been permanently established. The graph on this slide illustrates this concept with elegant clarity. From the homeostatic baseline, health deteriorates as undetected disease progresses. For a defined period, the reversible window, the body's compensatory mechanisms are still operating, and the pathological changes are still amenable to reversal with treatment. But there is a point of no return, the point of irreversible damage, beyond which intervention can only limit consequences, not restore full health. Secondary prevention's entire mission is to detect disease during the reversible window and deliver prompt treatment before that point of irreversibility is crossed. The mode of intervention at this level is early diagnosis and prompt treatment. Early diagnosis is achieved through two strategies. Screening programs examine apparently healthy populations, such as systematic examination of school children for nutritional deficiencies, visual defects, and developmental abnormalities, detecting disease before symptoms bring patients to clinical attention. Targeted testing focuses on high-risk groups, such as sputum examination and chest radiography for contacts of confirmed tuberculosis cases, identifying infection before it becomes symptomatic and infectious. Prompt treatment then stops communicable spread, arrests complications, and returns the patient toward the homeostatic baseline.
When secondary prevention fails, when disease is not detected in the reversible window and irreversible damage occurs, the patient enters the disability continuum. Understanding this four-stage progression is essential for community medicine examinations and for understanding the rationale behind tertiary prevention. Stage 1 is disease, the original pathological event or trauma. This is the biological insult that initiates the cascade. The clinical example is a severe road traffic accident causing crush injuries to the lower extremity. Stage 2 is impairment, any loss or abnormality of psychological, physiological, or anatomical structure or function resulting from the disease. The clinical example is the anatomical loss of a foot following traumatic amputation or vascular compromise. Impairment is defined at the organ or body part level. It is a deviation from normal biomedical structure or function. Stage 3 is disability, the restriction or lack of ability to perform an activity within the normal range expected for a person of that age and sex, resulting from the impairment. The clinical example is the inability to walk, a functional limitation at the level of the whole person. Stage 4 is handicap, the social and economic disadvantage experienced by an individual as a result of impairment or disability that limits or prevents fulfillment of a normal societal role. The clinical example is losing employment because the patient can no longer perform their job duties. This progression from disease to handicap is the target of tertiary prevention.
Tertiary prevention is the final defensive line in the prevention spectrum, operating at the stage of advanced, irreversible disease to restore the maximum possible functional capacity and prevent the progression of disability into social handicap. The primary tool of tertiary prevention is comprehensive rehabilitation, a multidimensional restoration process that addresses the whole person, not just the damaged organ. Rehabilitation in community medicine is organized into 5 interconnected domains. Medical rehabilitation encompasses surgical interventions and physiotherapy, for example, joint reconstruction surgery and physiotherapy to restore mobility in a patient whose hip joint has been destroyed by advanced tuberculosis. Occupational rehabilitation focuses on restoring the patient's capacity to perform activities of daily living, the routine self-care, household, and basic functional activities that define independent living. Vocational rehabilitation is the most examination-important domain. It specifically focuses on restoring the patient's capacity to earn a livelihood. The classic examinable example is providing an artificial prosthetic limb, not just for mobility, but specifically so the patient can return to their previous occupation and resume economic productivity. Social rehabilitation addresses the family dynamics and community relationships that have been disrupted or damaged by the patient's illness and disability, rebuilding social integration and support networks. Psychological rehabilitation addresses the inevitable impact of serious illness and disability on personal dignity, self-image, self-confidence, and mental well-being, restoring the patient's sense of identity and psychological wholeness.
Let us now apply the entire prevention framework to one of the most globally significant and examination-critical diseases in community medicine, tuberculosis, caused by Mycobacterium tuberculosis. TB remains one of the world's leading infectious disease killers, causing approximately 1.3 million deaths annually, according to the WHO, with the highest burden concentrated in South and Southeast Asia and Sub-Saharan Africa. At the health promotion level of primary prevention, TB control requires improving the social determinants of disease, adequate housing to reduce overcrowding, sanitation improvements, proper nutrition to maintain immune competence, and regular medical checkups to identify early disease. At the specific protection level, the cornerstone intervention is BCG vaccination, given at birth, providing partial protection against disseminated and meningeal TB in infants. Isoniazid chemoprophylaxis is given to close contacts of smear-positive cases and to immunocompromised individuals at high risk of progression. At secondary prevention, early diagnosis and prompt treatment, the Mantoux tuberculin skin test identifies latent TB infection. Chest X-rays and sputum smear microscopy confirm active disease. The DOT strategy, directly observed treatment short course, delivers 4-drug intensive therapy for 2 months, followed by 2-drug continuation for 7 months, monitored directly to prevent non-adherence and drug resistance. At tertiary prevention, corrective joint surgery repairs TB-destroyed musculoskeletal structures, while vocational rehabilitation and employment support address the socioeconomic consequences of prolonged illness.
Hypertension, sustained elevation of blood pressure above 140/90 millimeters Hg, is the world's leading modifiable risk factor for cardiovascular disease, stroke, and renal failure. The WHO estimates that hypertension affects approximately 1.28 billion adults globally and causes 7.5 million deaths annually. Applying the complete prevention framework to hypertension demonstrates perfectly how community medicine operates across all levels of the natural history of a non-communicable disease. At the health promotion level, the intervention is population-wide. Health education campaigns communicating the relationship between lifestyle and blood pressure, routine cardiovascular health follow-ups, and general nutritional guidance encouraging balanced diets and adequate physical activity. At the specific protection level, interventions become more targeted. Mandated dietary salt reduction through public health policy and food labeling regulations, structured smoking cessation programs, evidence-based obesity reduction initiatives, and prescribing active walking routines of at least 30 minutes of moderate intensity exercise 5 times per week. At secondary prevention, the mode is early diagnosis and prompt treatment.
routine blood pressure screening using sphygmomanometers at every healthcare contact, community hypertension camps, and initiation of evidence-based antihypertensive drug therapy when indicated. At tertiary prevention, the focus shifts to preventing the devastating complications of uncontrolled hypertension, stroke, hypertensive heart failure, and end-stage renal disease, followed by comprehensive social and psychological rehabilitation for those who have already suffered major cardiovascular or cerebrovascular events.
No community medicine course is complete without a thorough understanding of the World Health Organization, the international body that sets global health standards, coordinates responses to health emergencies, publishes the essential medicines list, and guides the preventative medicine agenda of every member state. The WHO was formally established on April 7, 1948, a date commemorated annually as World Health Day, with its headquarters located in Geneva, Switzerland. This founding date is a standard MCQ item. The WHO operates through 6 regional offices, each responsible for coordinating health activities across its geographic membership. The African Regional Office, AFRO, is headquartered in Brazzaville, Congo. The Americas Regional Office, PAHO, the Pan American Health Organization, is in Washington, D.C., USA. The Eastern Mediterranean Regional Office, EMRO, is in Cairo, Egypt. Pakistan is a member of EMRO. A useful memory aid, both the office location and the regional name begin with E. The Southeast Asia Regional Office, CRO, is in New Delhi, India, and covers 11 countries, including India, Bangladesh, Sri Lanka, Nepal, and Myanmar. The European Regional Office, Euro, is in Copenhagen, Denmark, and the Western Pacific Regional Office, WPRO, is in Manila, Philippines. These 6 regional offices, operating under Geneva's central governance, collectively implement the WHO's global health mandate across 194 member states.
Understanding where the WHO is located and when it was founded is necessary, but not sufficient for community medicine mastery. You must also understand what the WHO actually does, its functional architecture, because examination questions frequently probe candidates on the organization's specific mandates and activities. The WHO's work organizes around 3 primary functional pillars. The first pillar is governance and intelligence, the strategic leadership and information infrastructure of global health. Under this pillar, the WHO guides and advises national governments on improving the baseline quality and coverage of their health services. It obtains, standardizes, and disseminates vital health statistics from member states, creating the global epidemiological databases that inform international health policy. It directs and coordinates international medical and epidemiological research, identifying priority areas for investigation and facilitating multi-country studies. The second pillar is standard promotion, elevating the quality of healthcare practice and the conditions that support health globally. This includes raising educational and training standards for healthcare professionals worldwide, improving baseline nutrition across populations, advancing sanitation infrastructure, and working to improve occupational working conditions. The third pillar is global coordination, the WHO's role as the convening body for international health cooperation. This includes facilitating scientific collaboration among global research institutions, coordinating international responses to pandemics and health emergencies, and promoting mental health and family health initiatives across diverse cultural and geopolitical contexts.
Alongside the WHO in the global health infrastructure sits one of the world's most recognizable international organizations, UNICEF, the United Nations International Children's Emergency Fund. UNICEF was established in December 1946, initially as a temporary emergency response to the aftermath of World War II, and has since become the permanent global body dedicated to the survival, protection, and development of children worldwide. Its headquarters are jointly located in New York City and New Delhi, India. UNICEF's mandate is organized around 4 intersecting domains, all centered on child well-being. Disease eradication focuses on driving mass vaccination campaigns, specifically targeting the elimination of polio and measles, 2 vaccine-preventable diseases that still cause significant childhood morbidity and mortality in low-income countries. UNICEF has been the primary logistical driver of global polio eradication efforts alongside the WHO. Survival fundamentals ensure that children have access to the essential prerequisites of health: safe drinking water, basic hygiene infrastructure, and adequate child and maternal nutrition, including micronutrient supplementation programs for iron, iodine, and vitamin A deficiency prevention. Humanitarian aid delivers emergency educational and health services to children in conflict zones, natural disasters, and humanitarian crises where normal health infrastructure has collapsed. Child protection encompasses active intervention against child sexual abuse, exploitation, trafficking, and child labor, systemic violations of childhood rights that constitute major public health crises in themselves.
We conclude this lesson with 3 high-yield conceptual distinctions that appear with notable frequency in community medicine examinations, and that many students answer incorrectly because they confuse closely related terms. The first distinction is between medical care and health care. Medical care is confined strictly to the individual physician-patient relationship. It is the clinical encounter between a doctor and a sick patient. Healthcare, by contrast, is a far broader concept encompassing the entire community, families, and populations, including health promotion, disease prevention, environmental health, and all the social determinants of health. Every community medicine intervention you have studied in this lesson is an act of healthcare, not merely medical care. The second distinction is the definition of sustainable development, a term that appears in global health policy questions. Sustainable development means utilizing available resources to meet the health and developmental needs of today's generation without compromising the ability of future generations to meet their own needs. It is the equity principle applied across time. The third is McMahon's concept of prenatal versus postnatal disease. Prenatal disease is strictly determined at or after fertilization. It arises from genetic, chromosomal, or developmental factors acting from conception onward. Postnatal disease is driven by subsequent environmental deficiencies, infections, nutritional inadequacies, and maladaptation occurring after birth. Please like, comment, share, and subscribe to Studious for more high-yield medical education. Your board examination success is our mission.